Let's start this new video on the anatomy MCQs. We are into this 15th of March and we'll be dealing with the topics of the abdomen and pelvis, right? So this week we had abdomen and pelvis. One day we didn't made a video, but don't worry, we'll combine that. Okay, so without wasting any further time, let's start. Here's the first MCQ of the day. A 67-year-old lady is brought to the emergency by her husband because of 1 hour history of severe groin pain. So 67-year-old, 1 hour history of groin pain, nausea and vomiting. She has had a groin swelling that worsens with the standing, cuffing and straining for the past 3 months. So history is of 3 months, but pain and nausea and vomiting is of 1 hour history. Pulse is 120, tachycardia slightly. Examination shows pallor. There is swelling, erythema and tenderness to the palpation of the right groin. So there is swelling, erythema and tenderness to palpation of the right groin that is centered below the inguinal ligament. So all these inflammatory findings are there. The most likely cause of this patient condition is entrapment of an organ between which of the following structures. So I am sure by now we understood that it is a case of hernia. Okay, and that is a long history of around 3 months of swelling that is increasing on cuffing and standing. But for the past 1 hour, she is having all these pain. There is also swelling, erythema. So some inflammation has occurred. And the 67-year-old lady, it's a female, and that swelling is centered below the inguinal ligament. So looking at the sex of the sex that is a female and the swelling is below the inguinal ligament, it is most probably a femoral hernia, right? Because inguinal hernia is actually where it is above the inguinal ligament from the inguinal canal. So it's most probably a femoral hernia. Now they are asking entrapment of an organ occur between which of the following structures. Now femoral hernia occurs where? We should know that femoral hernia occurs through the femoral canal. And if we go to the anatomy of the femoral triangle, we know that the femoral canal is placed where? It is placed medially. It is placed medially. How to remember it? I told a mnemonic also before that we can remember it by the mnemonic navel, N-A-V-E-L, if you go from lateral to medial. What is this? These are the structures in the femoral triangle. Okay, so femoral triangle structures. So most lateral we have this N for nerve. Okay, most lateral we have this N for nerve, and then A for artery, V for vein, E for empty space, that is the canal where you have the lymph node. So hernia occurs to the femoral canal that is placed medially in the femoral triangle. Now they are saying, now look at the options. Option A is inferior epigastric artery and rectus sheath. If we look at the anatomy of the inguinal canal, let me just try to show you. Suppose this is the inguinal ligament, right? This is the inguinal ligament. And inguinal canal is from DIR to SIR, superficial inguinal ring. Just imagine this shaded area to be the inguinal canal. Now, the inferior epigastric artery is over here. This is the inferior epigastric artery. And the rectus abdominis muscle goes like this. This is the rectus abdominis. Now see, if the hernia is coming from the deep ring, this is indirect inguinal hernia. If the hernia is coming from this Hasselbeck's triangle, that is direct inguinal hernia. If the hernia is coming from this femoral canal region, that is the femoral hernia. That is most probably we are dealing with in this question. Option A is saying inferior epigastric artery and rectus sheath, that is through the Hasselbeck's triangle. So option A is referring to the direct inguinal hernia, not the femoral over here. Option B is conjoined tendon and inguinal ligament. Now conjoined tendon is a mixture of inferior or internal oblique and transabdominis, and that forms a roof. So between the conjoined tendon and inguinal ligament, we have what? We have the inguinal canal. So this is the inguinal canal region. That is actually part where the hernia would be coming if it is an indirect inguinal hernia, right? Then they are saying medial and medial umbilical ligament. So what is medial umbilical ligament? The medial umbilical ligament is actually the umbilical arteries which are now post-birth. They are of no use, so become ligament. And the median is actually the allantois or the urachus, we can call it. Now it is also a part of the direct inguinal hernia. Okay, why so? Let me tell you this, that this inferior epigastric artery which you are seeing over here actually forms a lateral umbilical ligament. The medial umbilical ligament will be somewhere over here. This will be the location of the medial umbilical ligament. The median is actually in the median part. This will be the median. So if I highlight it with this color, this area is actually what they are referring to, option number C. That is again a part of the direct or part of the Hasselbeck's triangle. Now coming to option number D over here, option number D says transverse cellus fascia and internal oblique epinosis. Now fascia transversalis is one of the most posterior layers in the abdominal wall, that is behind the trans abdominis. And internal oblique epinosis is the second layer of the muscle. Between these two, it doesn't make any sense. Between these two lies the transverse abdominis muscle. Option D also ruled out. Option E is lacunar vein and femoral vein. Let me just highlight it. Lacunar ligament, and femoral vein. Now, if you look at this inguinal ligament, which I have tried to make with this simple color over here, this being the inguinal ligament. Now, if we trace the inguinal ligament medially, if I show you with a different color, it revolves around like this to be a lacunar ligament, which actually proceeds posterior to be the pectineal ligament. So, this is the inguinal ligament that we all know, Popper's ligament. Medially, this is the lacunar ligament, and posteriorly, this is the pectineal ligament. Pectineal, right? Let me just clear it, the spelling here over here. Now, in the structures we have learned that in the structures in the femoral triangle we have navel, N-A-V-E-L. Okay, so this V is the vein over here. So this V is the vein. Imagine this A is the artery coming, and here we have what? This N is the nerve over here, yellow color nerve. Now in this empty space, what we have? We have a lymph node. Just imagine this being the lymph node. This is the area of femoral canal. Now, if I highlight this, then you can imagine that this is the area of the femoral canal where the femoral hernia will develop. And this femoral hernia is actually running where? This femoral hernia is actually running from our or between the lacunar ligament lying medially and the femoral vein lying laterally. This is the position of the femoral canal having femoral hernia, and that is option number E will be our best answer. You can see in the image also. I didn't show you this image earlier on, else you will get confused. So these are all the basics to understand. The same thing is the image being shown over here, and that is the region of the femoral canal in the femoral ring from where the femoral hernia will come. Okay, I hope the point is clear. Fair enough. Let's move to the next one. Okay, and the interesting question, be ready. A 33-year-old man, that is a young man, is brought to the emergency after being involved in a bar fight. Examination shows tenderness to palpation over the left side of the back. Left side of back. An X-ray chest shows a fracture of the 12th rib on the left side. So 12th rib fracture left side, it is already on the back because 12th rib doesn't come to the anterior aspect. So basically the whole case is what? Whole case is fracture left side 12th rib, that is the whole case. Though let me tell you, the lower ribs and the upper ribs, that is the first, second ribs, and the lower, that are the 11th, 12th ribs, they are very infrequently fractured. They are rarely fractured. The reason is that the upper ribs are covered by the clavicle and the lower ribs are actually freely mobile, but somehow it got fractured. Now the question is the further evaluation of most likely to show which of the following injuries. So you have to know that the 12th rib is related to which of the organs. Which organs are related to the 12th rib, be it right or left side? Say the left side. Okay. Now, if we try to make this as the vertebrae over here, say T10, T11, T12, or say T9, okay, T9, 10, 11 and 12. This is where the 11th and 12th rib, they come out, okay. The 9th and 10th rib, they will actually be circling around, then they go anterior to the insert, they form the costal margin on the side, so they actually move to the sides also. Now, if you remember, then 9th, 10th, 11th on the left side, which organ is placed over here? This is which organ? Normally 9th, 10th, 11th, we all should be knowing that we are referring to the spleen over here, right? Posteriorly. And posteriorly, if I now outline a sort of organ over here, say like this, which organ is this? Which organ do you think is this? I hope you will easily recognize it to be the kidney, okay. So on the left side, the kidney is related to, say, 11th and 12th rib. On the right side, the kidney is related mainly, it is said to be related only to the 12th because it is slightly inferiorly displaced because of the presence of the heavy liver on the right side. So kidney is very much related to the rib. Why so? Because kidney is purely retroperitoneal. It is just in front of the post-abdominal wall. Now see at the options. So you have a fracture left 12th rib. They are saying, can we have a liver hematoma? Very rare. Two things. Liver is mostly on the right side. Second, liver is intraperitoneal, not directly touching the ribs. So Pneumothorax. Now pneumothorax could be a possibility. Let me tell you this. Why so? Because these 12th ribs are, though they are present posteriorly, but you have the parietal pleura which is coming at this level. Remember 6, 8, 10, 8, 10, 12. We have done this in thorax also. Where if you go paravertebrally, the parietal pleura reaches up till the 12th rib area. So pneumothorax could be a possibility, though it is rare, but it could be a possibility. Remember, it is also seen when you are approaching the kidney from behind. Okay, so this could be a possibility. Then they are saying colon perforation. Okay, now colon perforation, okay, there are different parts. What parts we have? We have a ascending colon, then we have a transverse colon, then we have a descending, and then we have a sigmoid colon. Remember this, that this ascending and descending colon, they are retroperitoneal, fine, but they are more laterally located. And this transverse colon is more anteriorly because it is intraperitoneal. And this is sigmoid, that is more inferiorly. So colon is not directly related to the rib. Kidney laceration, I already told you, it is very, very high probability because it being an organ, kidney can easily be lacerated. Okay, so we have a pneumothorax, we have kidney laceration. Then pancreatic transaction. See, pancreas goes up till the tail of pancreas goes into the hilum of the spleen, no doubt about it. But the reason is that pancreas is anterior to kidney. Okay, so there will be initial kidney laceration, then there will be a pancreas. Okay, so this is the point over here, right? So we can go with option number B and D. In the option B and D, D has more probability than B, so we will go with the kidney laceration being as the answer. Beautiful question over here. So here we have this answer as a kidney laceration, and here you can see the image over here. Both, if you look at the right and the left hand side, in the right hand side you can see this is the outline of the kidney, and these are your ribs. We can call them as the 11th rib, and this is the 12th rib, right? They are showing the T12 over here. Look at the relation of the kidney over here on both sides with the 11th and 12th rib, right? That's very important. Okay, let's see the next question. 57-year-old lady comes to the physician because of several years of recurrent pelvic pain and constipation. She has increased, so 57-year-old, several years of pelvic pain and constipation. So pelvic pain and constipation. She has increased fecal urgency and a sensation of incomplete evacuation following defecation. She has had no problems associated with the urination, so bladder and the urethra looks okay, but there is some issue with the rectum anal canal and pelvic pain. Her last menstrual period was around 6 years ago, and she has had 3 uncomplicated vaginal deliveries. So 3 vaginal deliveries. Physical examination shows normal external genitalia. Speculum examination of the vagina and the cervix shows bulging, very good, of the posterior vaginal wall during Valsalva. So there is bulging of the posterior vaginal wall. Okay, so there is obviously some, you can say some prolapse or herniation of the posterior vaginal wall. And what is the relation of the vagina to the rectum? Vagina is in front of the rectum anal canal. Remember that. So it was a posterior vaginal wall that was bulging. So it is related directly to the rectum anteriorly. So rectum is behind and vagina is in front. Weakness of which of the following structures most likely cause of this patient's symptoms? Okay, so let me show you an image over here. Look at this image first of all. This is sagittal section, and what you are looking at is an anterior and a posterior aspects. Okay, so this is the V for vagina over here, and that is the A for anal canal. Okay, so the rectum and the anal canal over here, and this is the vagina over here. So there was a problem where there was a problem at around this side posterior vaginal wall. There was a protrusion during Valsalva. So now they are asking that the weaknesses, which are the structures. So if you look at the structures, first option they gave as the pubocervical fascia. The pubocervical fascia, pubo is the pubis part, cervical is the cervix of the uterus. So it is placed anteriorly and superior to the vagina. Fine, so that doesn't look like an option. Plus, the problem of the patient is in the fecal urgency and pelvic pain and constipation and sensation of incomplete evacuation. Now, rectum is related, we have discussed, behind the vagina and the cervix. So option A you can rule out. Rectovaginal fascia. Now rectovaginal fascia is exactly between the rectum and the vagina. So this could be a very good probability. So what would be the position of rectovaginal fascia? the position of the rectovaginal fascia will be obviously over here. This will be the location of the rectovaginal fascia. So here we are seeing the protrusion of the postvaginal wall, and that could lead also to the you can say bulging or herniation of the rectum. That could lead to that we can say simply, in simple words, there is a case of probably a case of rectocele, prolapse of the anterior wall of rectum through the vaginal wall. So it could be a case of rectocele, right? That is leading to all these problems. The rectocele is between rectum and the vagina. That is the fascia over here, and that fascia is obviously this is the rectovaginal fascia. Let us see other options as well before pointing out this to be the answer. Then option C, they are saying uterosacral ligament. That is again between the uterus, that is superior, and the sacrum behind. So it is one of the important supports of the uterus, not related directly to the rectum. External sphincter. Now this is a voluntary muscle which is acting as a sphincter or act as a voluntary control over the defecation movements. Right? So this is again no relation to the what we can say as a pelvic pain and constipation, because if there is a problem in the external sphincter, it will lead to incontinence, fecal incontinence. So we can rule this out. A cardinal ligament is a lateral cervical ligament, again an important support of uterus, but it is present laterally, also known as McInrod's ligament. So with all of this, we understood that it's a case of rectocele through bulging or weakness in the posterior vaginal wall. Okay, now there are various stages of it. Once it becomes very severe, then obviously the evacuation or the defecation process is always felt incomplete, and sometimes the female has to pass has to put pressure on the posterior wall so that the contents of the rectum are evacuated out. It could be in different stages. So probable answer over here anatomically is our rectovaginal fascia. I hope you got the point, looking at the basic anatomy over here. Fair enough. Let's see the next one. A 70-year-old man with a 1-year history of constipation, again constipation, comes to the physician for follow-up examination. He has bowel movements 1 to 2 times a week and sometimes has to use his fingers for stool evacuation. Again, there is a problem in the bowel movements. That's a very common problem in geriatric age group, remember that. Defecation is painful and preceded by a sense of bowel obstruction. So he is only doing bowel movements 1 to 2 times a week, and sometimes he has to use his fingers, and defecation is a painful process. Flexible sigmoidoscopy 2 months prior showed normal results, so that's a good thing. His current medication is a laxative, could be a drug like isofgol or lactulose solution or bisacodyl, could be any of that. But the abdominal examination shows no abnormalities. The digital examination of the rectum. So sigmoidoscopy is okay. Abdominal examination, simple examination, that is okay. But a DRE or digital rectal examination shows an increased resting and squeezing tone of the anal sphincter. So it's very important. See, any case of constipation in old age should check the tonicity of the sphincters, right? Should check before advising any drug. That is a preliminary examination finding in any constipated patient. So DRE shows an increased resting in tone, squeezing tone of the anal sphincter. So sigmoidoscopy was okay, examination was okay, fine, but DRE finds some issue. This patient's symptoms are most likely caused by dysfunction of which of the following processes. So now we know that there is some problem in the tonicity of the muscle, sphincter. So we should know about the anatomy. If I try to show you that suppose this is the rectum, that is the anal canal. Now we should know, knowing that here you have the levator ani, right? Or we can also call it as the ano rectalis, or not anorectalis, we can call it as a better name will be puborectalis, right? Not anorectalis, but that will be known as a puborectalis muscle. It is a part of the levator ani or part of the pubococcygeus muscle. Puborectalis, it forms a puborectalis sling. So what happens is, here we have the other muscles like external anal sphincter. Now this muscle also continues down over here as anal sphincters, right? So this puborectalis or the levator ani, you can call it as a levator ani group, they continue down as the anal sphincters. Now these are the anal sphincters over here. Now they are saying that they have found an increased tone during a DRE. DRE examination, suppose they place a finger over here, they found an increased tone around this area, right? Now they are saying dysfunction. The symptoms are due to dysfunction of which of the following processes? Let us see. First option is involuntary relaxation of external anal sphincter. They are saying that external anal sphincter is not able to relax, but involuntary. Is external anal sphincter an involuntary muscle? The answer is no. External anal sphincter is actually supplied by inferior rectal nerve, that is a branch of pudendal nerve. It is voluntary muscle. Involuntary relaxation of the iliococcygeus muscle. See, what happens is the levator ani or the pelvic diaphragm is formed by pubococcygeus plus iliococcygeus, right? Pelvic diaphragm, we have pubo plus ilio plus ischiococcygeus, okay? We have seen over here the puborectalis is a part of pubococcygeus, fine. So, relaxation of iliococcygeus muscle, they are saying that there is the iliococcygeus is not able to relax. Again, will not be correct answer over here because it doesn't form puborectalis part. Then they are saying involuntary relaxation of the pubococcygeus muscle. Yes, that could be a thing over here. Pubococcygeus, this is what is forming the puborectalis sling, is what we call it as. But involuntary relaxation, no. See, it is all about voluntary. These are all voluntarily controlled. Understand this part. Voluntarily controlled. When a person is defecating, in defecation, what is needed? Simply below the other muscles are given, but understanding the process over here. In a process of defecation, what is actually happening? First point is, you need to increase the intra-abdominal pressure, that we all know, right? So, increasing intra-abdominal pressure, the pressure will go down. Okay. Now, as the pressure goes down, you need to relax what? You need to relax the levator ani muscle voluntarily. That is voluntarily relaxation. And simultaneously also have to relax the anal sphincter. That is also voluntarily. These sphincters and the pubococcygeus or the levator ani, they are voluntarily controlled. Now, they are say involuntary, it is wrong. It is all voluntary over here. So, now we come to the option number D and E. They are talking of the voluntary relaxation of which muscle? Puborectalis or internal anal sphincter. Now, see, here as we talk of the sphincters, here basically the external anal sphincters are the ones which are supplied by inferior rectal nerve, voluntarily controlled. While the internal anal sphincters, they are actually a continuation of the muscularis layer of the rectum. So, rectum, a part of the gut, has a muscularis external layer. Their continuation is what is the internal sphincter. So, it is again involuntarily controlled because it is supplied to autonomic system. So, we are actually left with option number E, that this patient condition where you have the increase in the tone of the sphincter is due to dysfunction of the voluntary relaxation of puborectalis muscle. So, puborectalis muscle is not able to relax voluntarily. See, we need to, as I told you over here, for defecation process, we need to relax the levator ani or the puborectalis voluntarily, or we need to relax the external anal sphincter over here, not the internal. Because see, internal anal sphincter is a continuation of the muscles of the rectum, muscles of the gut muscles which help in peristalsis are involuntary muscles. I know slightly a longer discussion, but that is what is needed. Okay, proper defecation. These are all the muscles that are shown over here. Fair enough. Let's see the next one over here. A 22-year-old lady with polycystic ovarian syndrome comes to the emergency department because of, so it's a young lady with PCOD, comes to emergency, 1 day history of left lower abdomen pain that began suddenly and while she was running. So, young female running, she developed pain in the left lower abdomen. Her LMP was around 2 weeks ago, so this is somewhat around the ovulation time, we can say. Physical examination shows tenderness to palpation over the left adnexa and rebound tenderness in the left lower quadrant. There is tenderness and rebound tenderness. So, this is involvement of the surrounding, you can say surrounding structures as well. There is no tenderness in the right side. Urine pregnancy test is negative, so pregnancy is ruled out. Right side is okay. Ultrasound is ordered to confirm the diagnosis. Now, diagnosis confirmed of the ruptured ovarian cyst. PCOD case, ruptured ovarian cyst on the left side. Simple as that. Visualization of the fluid in which of the following locations would be most consistent with this diagnosis? So, where would you look at the fluid connection? Because ultrasound has diagnosed it to a ruptured cyst. So, the content of the cyst will come out and they will be localized at some place. Which place is that? That is what they are asking. So, will it be, see, lesser sac is behind the stomach. So, please rule it out. Okay. Recto-uterine pouch or the pouch of Douglas is the most dependent space in a sitting or standing female. If you look at this image over here, this we know is the rectum, this we know is the U for uterus. I put highlight over here, this is the recto-uterine pouch, this is the recto-uterine pouch, most dependent space, also known as pouch of Douglas. Here we always see the fluid collected in the abdomen of the pelvis, in a female particularly. This is a very good answer. Let's see other options as well. Hepatorenal pouch or hepatorenal space, or known as pouch of Morrison, is between the liver and right kidney, and that is most dependent space also, but in a lying down position, a supine position. Okay, but here in case of adnexa, rupture ovarian cyst, we are dealing with a pelvic abnormality. Splenorenal angle. Now, splenorenal angle is the angle between the liver and the spleen, the kidney and the spleen, right? The left side, obviously. Rectovesical pouch. See, rectovesical pouch is seen in males. For males, we don't have a uterus. We have a rectum. In front of that, we have the urinary bladder. So again, we can rule out option D and E. Splenorenal angle again is the total abdomen part. So what we are left with is simply recto-uterine pouch or the pouch of Douglas, right? So remember these questions over here. And I hope you're enjoying. So we'll meet again the next week with other few important MCQs. Do comment if you like something or you want to add something else in the future videos. That's all. Thank you from my side.